Patients required fluid and antibiotics. A strict monitoring in the ICU is necessary, with elective ventilation preferred in all these. A nasogastric or nasothoracic stomach tube is a must to decompress the stomach, and if it is avoided, then a gastric dilatation could be a disastrous possibility. Chest X-ray should always be done to detect for any pneumothorax, if any. It may be unilateral or bilateral. This is more so true in case the child is having respiratory distress and not able to maintain ventilation despite ventilatory support. Another important issue is that these all newborns require good pain relief, and we prefer to put an epidural catheter in the newborns and then to give the titrated dose of the painkiller so that they remain pain-free throughout the post-operative period. And this helps the speedy recovery of these patients. We also leave a drain in the neck at the site of the anastomosis to detect the leak, if any. Only few patients require total parenteral nutrition. Otherwise, we have used jejunostomy to promote early feeding in the post-operative period. However, our complication rate following jejunostomy has been high, hence it has not been a preferred procedure with us. We also prefer to give repeated doses of the plasma during the first 5 days in the post-operative period, and this might require 10 ml fresh frozen plasma given almost 6 to 8 hourly. Next slide. This shows the gastric pull-up of the patient on post-operative day 7 only. The patient has come out of the post-operative period, and this dye study shows no leak in the neck and a thoracic stomach. Next slide. It shows 2 other newborns on day 3 and day 8 in the post-operative period. Next slide. This shows the post-operative gastric pull-up followed up at 6 months. The dye study shows thoracic stomach and with no dilatation and no redundancy. Next slide. This slide shows the experience with the gastric pull-up at our institution during the past almost 20 years. In all, we have done 51 cases, but that includes the newborns and children. However, the major indication for gastric pull-up has been the Tracheo-Oesophageal Fistula and esophageal atresia, and this included the difficult Tracheo-Oesophageal Fistula, maybe with the post-leak, and esophageal atresia with wide gap. 41 out of 51 were the cases belonging to the TEF group. Only 9 cases with post-corrosive strictures included in the gastric pull-up, and only 1 was with post-candida esophageal problem. Another important factor to note from this slide is that out of 51, 31 had been done in the neonatal period from day 2 to day 31 in first month of life. 14 were done during infancy and only 6 were done after first year of age. Next slide. This slide shows the world experience with the esophageal replacement in newborn period. This is not for the first time that we have replaced the esophagus in the newborn period. Attempts have been made as back as 1948 with the use of colon, again in 66 colon, and 67 again in colon, 1970 again colon, and it was 1980 for the first time that Atwell tried to use the stomach, and 2 of the 4 patients survived and 2 died. Gomez again 1996 used stomach for the first time in the newborn period in 1 patient, and this survived. And he also used colon in 6 patients, and 3 of these 6 died. The present series includes use of the stomach in 31 newborns, and 26 of the 31 have survived. This seems to be the largest series reported in the English literature to the best of our knowledge. Next. The slide shows the use of stomach as a replacement of the esophagus, and the largest experience was reported by Lewis Spitz, and he commented that no symptomatic deterioration in the function of the transposed stomach was seen after the first decade. Also, the overall outcome was found very good, and he commented that gastric transposition is a satisfactory means of esophageal substitution and probably the best as of now from the available options. This he reported in 2004 in the Journal of Pediatric Surgery. Next slide. This shows the gastric pull-up follow-up in patients from 6 months to 85 months, and we did the studies to find out how the thoracic stomach is behaving as far as the transit time is concerned, the gastric clearance is concerned, the duodenogastric reflux, and the pressure in the stomach, and many other parameters. We found that 2/3 of these patients had normal transit time at 12 months. So also was the finding with the nuclear scan gastric clearance studies that almost 2/3 of these patients had normal gastric clearance. 1/3 had shown delayed clearance or even physiological obstruction, but there was no mechanical obstruction detected. When we talk of duodenogastric reflux, it was found that almost 40% of these had presence of the duodenogastric reflux at 1 year of age. However, though it was detected, but most of the patients were asymptomatic, hence requiring no treatment. As far as the rise in intragastric pressure is concerned, in response to the bolus feed given, we found that 2/3 of these patients showed rise in the gastric pressure in response to the bolus feed, and we will talk about it in detail. The next slide shows that the long-term studies after 5 years of the gastric transposition with a mean follow-up of 7.6 years shows that 80 to 90% show a decrease in height as compared to the normal population or with those who had been prepared for TEF with primary anastomosis. Thus, this is an issue that requires a long follow-up and a matter of concern. The weight of these patients also remains subnormal in almost 2/3 of these patients. However, good part is that when gastroscopy was done, in almost all, there was a normal gastric mucosa. The gastric biopsy was also done, and in most of these, there was a normal gastric biopsy except in 3 which showed mild gastritis, hence of no concern. When we estimated the 24-hour pH study, it was found low, and despite vagotomy, it is not a matter of concern because the pH was found as low as 1.7 to 3.6, and it is a good sign. Next slide. This slide again shows the outcome of the gastric pressure profile, that when we compare the gastric pressure profile in neonates versus children, it was found that the pressure was high in neonates as compared to that in children. Also, the route, whether it was a hiatal route or substernal route, it did not matter. The pressure remained the same. The level of the pressure in the stomach, that increased by 120%, and it was quite significant in response to the bolus feed. Thus, the stomach shows a contraction whenever the bolus is given. Whenever bolus was given, almost 2/3 of the patient responded with this activity. Hence, it shows that stomach is not an inert organ when it lies in the thorax. It does respond to bolus feeds, and that is a good sign again. What happens to the pulmonary function test in such patients? In our series of 10 patients, we found that half of them showed normal pulmonary function tests and half of these had abnormal ones in the form of reduced pulmonary capacity. Hematological tests were also done for anemia, but fortunately all of them had the normal studies for hemoglobin, though the iron stores were found poor in 70% of these cases. Next slide. This slide shows that why stomach still is a preferred organ to replace the esophagus in the newborn period especially. That stomach is feasible even in the neonates. It is very well accepted as shown from our series in almost 85% cases who survived. It offers an early and definitive procedure. It is readily available and there is no suture line in the thorax when performed. It can be used even in the presence of sepsis, because especially if after the primary anastomosis there is a leak, there is always a pleuritis or even empyema. And in this situation, if we consider use of the colon as a colon transposition to replace the esophagus, then its blood supply is very tenuous and the vessel may get thrombosed because of the ongoing inflammation. However, stomach is a very vascular, muscular organ and with a very rich blood supply, hence there is no risk of the gastric supply getting thrombosed. It can be used in emergency and usually there is no need to prepare the stomach as and when it is required to be pulled up to the thorax. Next slide. All is not that well and some concerns always remain with the use of the stomach to replace the esophagus. The newborns who get esophageal replacement using stomach in the newborn period, they require prolonged ICU care. They also require ventilatory support. They also require parenteral support for nutrition. They also require prolonged pain relief. And this is a major procedure and should be undertaken only by the experienced surgeons who have done sufficient number of newborn cases, especially the TEF repair. And this should be done only in rare cases with a dependable nursing care and dependable neonatal surgical ICU care. A pyloromyotomy or pyloroplasty, both are good and must be done, because when stomach is pulled, when stomach is mobilized in the abdomen, vagotomy is part and parcel of the procedure. Hence, to avoid any stasis in the stomach after vagotomy, a drainage procedure should always be considered and provided. I personally prefer to do a pyloromyotomy rather than a pyloroplasty. How about the route? Any route is good enough while pulling the stomach. I prefer to use the hiatus route for all newborns. However, if it is a child or infant or even in older children, I prefer a substernal route, because by then the hiatus route is narrow and it is difficult to house the stomach through a hiatus route. Hence, I prefer to use a substernal route for that, and though it is little longer, but it has not been a problem in my experience. Another point of concern remains a leak in the neck with the primary anastomosis of stomach to the esophagus. The leak rate has been about 40% in our hands, However, the good part is that almost all of them they healed, and we never required a redo procedure for such a leak in the neck. Next slide shows our few publications with the use of the stomach in the newborns and also in children during the past 18 years. These have been published in various journals including European Journal, Asian Journal, Pediatric Surgery International, Journal of Indian Association of Pediatric Surgeons, Journal of Pediatric Surgery, even seminars in pediatric surgery, and Journal of Public Health. Thus, ladies and gentlemen, esophageal replacement in the newborn is not something very common procedure. However, we have adopted in our children as a compulsion and not as a preference, because our situation is different. Our experience had shown that primary anastomosis is still the preferred method. However, whenever it has not been possible, feasible or practical in such cases, we had to resort to other procedures. Myotomy has not been a preferred procedure. Use of the flaps has not been a preferred procedure. Kimura's technique, Charlie's technique or focus technique have also not been found very much favor in our setup. Delayed procedure is not something that we will prefer because it requires a prolonged stay in the ICU. Neither we can afford it nor it is feasible. Rather, we are always apprehensive that if we delay the primary anastomosis and keep these newborns for weeks and months in our ICU, possibly they will die because of septicemia developing either from the infection of the ulcerations and erosions of the upper pouch or oxygen insufficiency while being on continuous suctioning. Hence, these methods, when not found feasible, we have to adapt to something different. And doing a definitive procedure in the newborn is something that the parents prefer, and stomach is the only one that can replace the esophagus in the newborn period, and that has been our procedure. Colon is not something that should be considered or preferred, because these are the cases, especially after the major leak in the chest. Colon should not be used because it has a tenuous blood supply and the arcade can get easily thrombosed in the presence of infection in the chest. Hence, it will produce disastrous results. Our preference thus has been to use the stomach that has got a very good blood supply. This is quite vascular and this is quite muscular organ, and this can be used even in the presence of sepsis. We have used it in many patients who already had chest infection, who had even empyema, who had even major leaks, and this has got good results in our hands. With these comments, I wish to thank once again for inviting me and delivering this talk during this meeting. Thank you very much, and thank you, Gyamba, for taking care of this.